Hello, AP2 students. This is Mrs. V again. We were talking about electrolytes and electrolyte balance, and we are looking at sodium, potassium, and calcium, our big three. And so now we're going to talk about imbalances. Since it is going to be through the kidneys that we have our number one loss of electrolytes, so through urination, all electrolyte imbalances can be caused by kidney disease. We get the majority of our electrolytes from our diet, so from our foods and from the things that we drink. And we can also lose them through vomiting or through diarrhea. So any sort of dietary deficiency, if someone has other disease that causes them to have a lack of absorption from the small intestine, or like I said, if someone's having major losses from the gastrointestinal tract, so vomiting, diarrhea, if they have to have gastric lavage, have their stomach pumped, they all of these things, of course, can cause an electrolyte imbalance, and someone's electrolytes would be low. Since these ions are all involved in nerve signaling and muscle contraction, when we go through these imbalances, whether they're high or they're low, what you're going to see is all of them can cause problems with the nervous system, so thought processes, and all of them can cause problems with muscle contraction. And so we're just going to make some generalizations. And this is kind of the part I think, we can realistically get to this level of understanding. So let's think about it. So remember, oh, this is back from AP1. There's our action potential. And so there's two parts to an action potential, and that is that depolarization. That's when sodium moves into the cell, and then we've got that repolarization when potassium leaves the cell. For a neuron, that action potential goes down the length of the axon, and then to release that neurotransmitter, that's when calcium is required. Okay, so think about it. Now you have an imbalance either in sodium, potassium, or calcium, so now your neurons aren't firing properly. Okay, so let's think about how a patient with this neurological dysfunction would present to you. Let's just talk about cognitive abilities. So what do you think? Are they going to be spot on that day? They're just going to be able to solve math problems in their head. What do you think? Okay, well, hopefully you kind of thought about it, at least for a brief moment. I didn't give you a whole lot of time. But yeah, you're going to see things like your patient may be confused. They may feel lethargic, meaning they just feel really tired or kind of mentally sluggish. They could go all the way into a coma. You could have it going the other end where their neurons are just firing inappropriately. And so you could also get agitation with your patient. Okay, so let's look at muscles. Remember, we've got our smooth muscle, we've got our cardiac muscle, and we have our skeletal muscle. So now we're saying there's electrolyte imbalances, and we know that all of them, sodium, potassium, calcium, are involved in muscle contraction. So your smooth muscle, that lines hollow organs, remember, and so this is giving you a nice little picture of the digestive system. All right, so what might someone be feeling if there were an electrolyte imbalance as far as their digestive system? You might feel a little nauseous, maybe some diarrhea or some constipation or some vomiting. Yeah, any of those things could be thrown off. Let's go over here to the cardiac muscle. We already did cardio, so you can have arrhythmias, you could have a slow heartbeat, you could have bradycardia, you could have a fast heartbeat, tachycardia. The heart could actually stop. You could have cardiac arrest with electrolyte imbalances. Let's pop over here to skeletal muscles. So this is for movement. So you could have anything ranging from, you could have weakness, you could have all the way to paralysis, you could have just muscle spasms, a little twitchy, all the way to tetany, and then you could also have like involuntary movements. So all of those things you can just kind of think about it, go, okay, if my muscles aren't working, what might happen? And so you're going to see all these different symptoms and signs with your patient. Okay, so first thing, let's jump back into it. What two hormones influence sodium levels? Yep, this is so much harder without you here. I can't see your little faces, can't hear you answering, but hey, I'll give you a hint. They both begin with A. All right, so the number one is going to be aldosterone, because we know that aldosterone from the adrenal cortex is going to cause sodium to be reabsorbed at the distal convoluted tubule and collecting ducts of the kidneys. What's the other one? What's the second one? Oh, you're so smart. I'm imagining you just being brilliant. Yes, ADH, so anti-diuretic hormone. We know that because sodium is the #1 electrolyte in the extracellular fluid, that it is tied, its fate is going to be tied also to water. And so ADH can also affect sodium levels because more water dilutes out sodium, less water would concentrate sodium. So ADH is also going to have a little play here. Okay, so let's look over here on this side. So hypo means low, natremia refers to sodium. So that's the Latin name right there, so Na. So hyponatremia is due to low sodium, so you can be losing your sodium, or you have too much water. Either way, what's going to happen, so pop over here and look at our picture. What we have is we have more water, less sodium in that extracellular fluid compartment. So what's going to occur is water is just going to move based by osmosis into the cells, and we're going to get cells swelling. Cell swelling in the central nervous system is not a good thing. So you're going to see some neuromuscular dysfunctioning. You're going to see some confusion, lethargy, coma, and even death. And we talked about that already with that water intoxication. So hyponatremia, water intoxication are kind of basically the same thing. So you're going to have neurological brain swelling. So very bad. You can be losing your sodium from the gastrointestinal tract through sweating, kidney disease. Certain diuretics can cause that to occur. Perhaps there is a lack of aldosterone, so Addison's disease. And then we talked about that. You could basically dilute out your sodium by hypotonic hydration, so that water intoxication. ADH, you could be releasing too much ADH. So remember that syndrome of inappropriate, sorry about that, inappropriate antidiuretic hormone. So you could also just be holding on to too much water and diluting out your sodium that way. So hyponatremia, we have low sodium values in the extracellular fluid, and that's the same basically as that water intoxication. So let's pop over here. So hyper means above. So we have hypernatremia. So now we have a high sodium content, or you can also get there by losing water. So low fluid content. So either way, this is what we have going on. Now we have these little green balls are going to be the sodium. So you have a whole lot of sodium, not a lot of water. So now we're going to get the opposite to occur. Water is going to move from the intracellular fluid to the extracellular fluid space. So we're going to get some shriveling cells. So here we are, it's all shriveled. These red blood cells are cranated. And so the symptoms that you're going to see, once again, neuromuscular dysfunction. So pop up here. There's a little mnemonic. This is from nursing website. So salt, you think salt and sodium. So someone with hypernatremia, they're going to have flushed skin. They're going to feel agitated. So now we're going the other way. They may have a low-grade fever. Since they're going to be salty, they're going to have a high osmolality. Hopefully their thirst center is triggered. They're going to be super thirsty. And then we can have some dysfunctioning with their heart rhythms. So we can have a fast heartbeat, so tachycardia. How you can get hypernatremia. So remember, aldosterone causes that reabsorption of sodium. So we can have hyperaldosteronism. And so that could cause that. You could also be losing all your water, so through dehydration. And like I said, you really want to look for the elderly in this. They often will get dehydrated. They just have that diminished sense of thirst. Or someone is just losing a lot of fluids and they have limited access to fluids. Another way too is someone with diabetes insipidus, they can't make antidiuretic hormones, so they can't retain their water, so they could be losing fluids, and they might get to that hypernatremia if they are not taking in enough fluids. Okay, so that was sodium. So next one is potassium. What one hormone influences potassium levels? So whatever you see an imbalance, sodium or potassium, like on your test, I want you to think aldosterone. Aldosterone causes the reabsorption of sodium, but it causes the secretion of potassium. So oh, I just gave that one to you. All right, so does aldosterone raise or lower potassium levels? Yes, it's gonna lower it. Okay, so for the most part, look down here first. This is just showing under a normal American diet. In the normal American diet, we are usually secreting potassium, meaning most Americans take in excess potassium, and how we get rid of our electrolyte excess is through urination. So most of the time, we have more than enough. But at times, you can have hypo, so low, kalemia, potassium, emia means in the blood. things that can cause this. You can lose a lot from the gastrointestinal tract, either by vomiting or diarrhea. You can sweat too much and not be taking in electrolytes, kidney disease, diuretics. You're kind of seeing that this kind of all sounds the same, doesn't it? Two, you can also get there if someone is secreting too much aldosterone, then they are going to be excreting too much potassium, so excessive loss. Once again, it's an electrolyte imbalance, so we are going to see neuromuscular dysfunctioning. So in this case, we have bradycardia, which is a slow heartbeat. That smooth muscle is not going to be working right. So we're going to have some nausea, some vomiting, some diarrhea. And so that's hypo, low, kalemia, potassium in the blood. So let's pop over here. We've got hyperkalemia, the other end of the spectrum. So now we have high potassium. So high potassium in the blood. So this is going to be due to a lack of excretion. Like I said, most of the time we are taking in too much. So that can cause that is low aldosterone. And remember the name for that was Addison's disease. And of course, kidney disease. There are some drugs that inhibit the renin, angiotensin, aldosterone system, and they're called ACE inhibitors. And these are commonly prescribed for hypertension, so for high blood pressure. So maybe someone's dosage is off. That can cause high potassium in the blood. Once again, we're going to see neuromuscular dysfunctioning. So someone can have weakness, they can feel fatigue. The danger with hyperkalemia, it's actually pretty serious, is you can have life-threatening arrhythmias, meaning that hyperkalemia can actually stop a heart. So kind of help you remember that. I don't know, maybe you're home streaming a lot these days, could be. I don't know if you ever saw the movie Law Abiding Citizen. Pretty intense movie, kind of violent. It's a good movie. There are 3 drugs that are typically used in a lethal injection, and in the movie, I don't want to spoil it for you, but they're over here and has something to do with that. But the last drug that's normally given is going to be potassium chloride. First, they induce unconsciousness, then they give them something to stop muscle action, and then they actually stop the heart with potassium chloride. And so too much potassium, neuromuscular dysfunctioning can actually stop the heart. Okay, and our last one that we're looking at, what is the #1 hormone that influences calcium levels? Parathyroid hormone. Okay, does parathyroid hormone raise or lower calcium? Yes, it raises calcium. See how easy this is? You guys are so smart. So now we're looking at balances, and you've seen this before. So a really easy way to remember, because once again, we're going to have neuromuscular dysfunctioning, is it's going to be opposite. So if calcium is high, neuromuscular functioning is low. If calcium is low, neuromuscular functioning is high. So let's pop over here. So hypo means low, calcemia, so low calcium in the blood. So it's going to be opposite. So what you're going to see with that is you're going to have increased neuromuscular excitability. Okay, so you can have everything from convulsions, arrhythmias, tetany, and spasms. So now we have overactive muscles. If hypocalcemia is chronic, meaning just over a long period of time, if it's caused by diet, what you're going to see that show up in the bones. So osteomalacia is soft bones in adult. You're going to see some fractures. It's called rickets in children, soft bones, and can actually cause bending and curving of the bones in the lower appendages. What can cause it? Since our #1 hormone controlling calcium levels, if it's not dietary, it's going to be caused by hypoparathyroidism, so low output from the parathyroid gland. It could be genetic, it could be surgical from removal of the thyroid gland. It could also be autoimmune to, like I said, dietary, so poor intake or absorption. And this could be either for calcium or for vitamin D, because we need vitamin D to absorb our calcium. And so those would be the causes of hypocalcemia. So let's pop up over here. So now we're looking at the other end of the spectrum. So hyper means inflated or high. Calcemia, calcium in the blood. And so if this is high, that means neuromuscular functioning is low. Confusion, you're gonna have muscle weakness, lethargy, and then you're gonna have some arrhythmias. So if calcium is high, neuromuscular functioning is low. If it's chronic and it goes on for a long time, there's a little saying that clinically is used: stones, bones, groans, and psychic overtones. So if you have hypercalcemia, one of the things, stones, there's going to be a higher chance of kidney stone formation. There's going to be problems with the bones. You're like, oh, but there's so much calcium. No, there's still going to be osteoporosis and then some pain associated with that. And then once again, we're going to have some psychic overtones, so that decrease neurological functioning. Causes are going to be the opposite. So now we've got too much parathyroid hormone, and so there's too much calcium in the blood. It could be either due to a tumor, or then there's certain cancers too that cause the parathyroid gland to release too much hormone and those elevated calcium levels. All right, so let's think about it. What effect would hyperparathyroidism have on the bones? Are they really strong, or do you think that they're going to be weak? Hopefully you said you thought they were going to be weak, and that is actually true because parathyroid hormone stimulates those osteoclasts. If it's chronic and over a long amount of time, the bones are actually going to have this sort of moth-eaten appearance to them, so porous bones. Okay, what effect would hyperparathyroidism have on the kidney? Oh, what did I say? What was that? So we're talking about hyperparathyroidism leading to hypercalcemia. Yep, so you have an increased risk of kidney stones. The majority of kidney stones are going to be calcium based. So if there is excess calcium in the blood, that means there's going to be excess calcium in the filtrate, and more calcium, less water, higher likelihood of them to crystallize and form renal calculi, form kidney stones. Talk to you next time.